I am Ilan Timor. I am giving this lecture, Cesarean Scar Pregnancy and Morbidly Adherent Placenta, on my behalf and behalf of Dr. Monteagudo. We are part of the New York University School of Medicine, Department of Obstetrics and Gynecology. I have no disclosures and no financial relationships at this time. After completing this presentation, the learner will be able to diagnose a cesarean scar pregnancy by their diagnostic criteria and differentiate it from the intrauterine pregnancy and the cervical pregnancy. You will also be able to recognize that there is a common histologic basis of scar pregnancy and morbidly adherent placenta, such as accreta, increta, and percreta, and that scar pregnancy is its main precursor and a major risk for morbidly adherent placenta. You will be able to construct an evidence-based counseling and management plan for the scar pregnancy, considering the patient's obstetrical goals. You will be able to recognize the sonographic findings of morbidly adherent placenta and those of the MRI features of the same. Here is the lecture outline, which you can look at when you log in and listen to this lecture. I won't repeat them. But first, what is a cesarean scar pregnancy? It is an iatrogenic entity. When a blastocyst implants in a microscopic or macroscopic tract on the uterine scar or in the niche left by the incision, in the anterior uterine wall, developing into a chorionic sac. The mechanism is similar to the implantation after uterine surgery, myomectomy, curettage, ablation of the endometrium, manual removal of placenta, and many others. What is it? It's a dangerous pregnancy, presenting serious diagnostic treatment and counseling challenges. There are many synonyms in the literature, such as scar pregnancy, cesarean section scar ectopic, and cesarean scar ectopic. It is mistakenly considered an ectopic pregnancy. However, remember, it is low, but still within the uterine cavity. And if left alone, the sac will morph into the uterine cavity with the pregnancy in it. Unless real ectopic pregnancies, this kind of pregnancy can result in a live neonate. Here is an interesting little depiction of how it comes about. The fertilized oocyte travels into the uterine cavity, it overshoots, implants in the scar and the niche, it sprouts a small trophoblast and placenta, which then, without a normal barrier, invades the myometrium and gives rise to a scar pregnancy or placenta accreta. How does the scar section niche or scar look? On ultrasound, most of the time it appears something like this. You usually look at it on the sagittal plane as seen here. However, be aware of the fact that it has a width following the transverse incision line. I will talk about this later. I recognize two kinds of implantations, one on the scar, and in this case, you will see that there is a scar present and the placenta outlined by arrows implants on top of the scar. There is a distance between the anterior uterine wall and the placenta. And then there is one that's implanted in the niche, and if that is so, then you will see the placenta very close to the anterior uterine wall, or for that matter here, the bladder, and you will see the vascularization right there depicted by the arrows. There are several theories of the pathogenesis. Previous uterine surgery or uterine interventions lead to a thin or very absent deciduum basalis in the scarred areas of the lower uterine segment. And you can see that here, that this missing nitabuc-fibrillin layer, which in the normal placenta is depicted by this line, and prevents the villi into penetrating the myometrium. On the right side, you see that the villus penetrated deep into the myometrium without having any kind of barrier in front of it. This is also depicted in this picture, where the villus tissue is seen wedging into the myometrium. The incidence is not known, and it is presumed that it is 1 in 2,000, 2,500 cesarean deliveries. The rate is closely related to those of the cesarean delivery rates. And remember that about half of the scar pregnancies had only one prior cesarean delivery. The more previous cesarean deliveries, the more cesarean scar pregnancies, the more previa and the more accreta. How do we make the diagnosis, and which are the differential diagnoses? The sonographic diagnosis is reliably made in the OBGYN office by transvaginal sonography. Don't outsource it in any other imaging laboratory. The diagnostic accuracy depends on the expertise and understanding its differential diagnostic issues. The question is, should you order an MRI to diagnose or to confirm a sonar diagnosis of a scar pregnancy? Well, you could, but it's definitely not necessary. Why outsource? Why delay the diagnosis? The first-line imaging is transvaginal ultrasound. The criteria to diagnose it are the following: no fetal parts in the uterine cavity or cervix, thin myometrial layer between the bladder and gestational sac. In the beginning, a triangular wedged-shaped gestational sac, and then the gestational sac is close to the bladder and the anterior uterine wall. At times, rarely, an AV malformation is seen at the site of the cesarean section scar. That can be recognized by its rich vascularization and also by its high peak systolic velocity if you do measurements of that, as well as a low, the high resistance index. The differential diagnosis, first of all, is a cervical pregnancy. However, remember, it's extremely rare and occurs cervical pregnancy occurs in intact uteri. The interterm pregnancy in the process of abortion can give you the false diagnosis. However, they very rarely have a beating heart. Therefore, and remember this, if the chorionic sac is low in the uterus, close to the cervix, and the patient had a previous cesarean delivery, it is therefore a scar pregnancy. The easiest and simplest way to the diagnosis is, on a panoramic longitudinal sagittal scan, you determine the location of the gestational sac. You divide the uterus in half by an imaginary line, and if the center of the gestational sac is above it, it is mostly a normal implantation. If the center of the gestational sac is below it, suspect a scar pregnancy or even a cervical pregnancy. It has a very high sensitivity and specificity. But I warn you that at times, mostly after 7 weeks, the location of the sac may be misleading. Rely on the patient's history, location of the placenta, and its vascular supply. Let me demonstrate this to you. After 7 to 8 weeks, you will be fooled by the location of the sac. The sac may move up, but the placenta with its vessels stays at the implantation site. Rely on the color Doppler of the vessels at the scar implantation site. They stay anchored. Don't promise your patient that it may not reoccur. In the literature, there are several instances that they describe recurrent cesarean scar pregnancies, 2%, 1.2%, and even in one article, 3.4%. I will have to tell you the curiosity of our 5 consecutive cesarean scar pregnancies, in which the last one resulted in a normal neonate, but the patient lost the uterus for accreta. What is the natural history of scar pregnancies? They have 2 stages scar pregnancy and morbidly adherent placenta are two stages of the same disease. They share the same histology. We published this article on the cesarean pregnancy and proved that they share a common histology. The question is now, is there an accreta per creta in the first trimester? And it suggests that possibility of placenta accreta. You can see that in this picture of a 7-week, 3-day scar pregnancy. The second question is there an accreta and percreta in the second trimester? In the early second trimester, findings may be seen as early as 13 to 18 weeks. Here is a case that was imaged at 14 weeks. It ruptured several weeks later, and the histology was percreta. The patient, of course, lost the uterus. Here are 4 articles comprising 40 cases of scar pregnancies in which the patients mostly made it to the delivery of neonates, and it proves that CSP is one of the precursors of the placenta accreta. What is the natural history? Well, I already said that scar pregnancy is a precursor of morbidly adherent placenta, and the second article that we published is a proof of it, and very clearly shows in presenting 10 cases of scar pregnancies which morphed into morbidly adherent placenta. The cases in the literature validate the fact that really scar pregnancy is the precursor of a morbidly adherent placenta. Pregnancies start out with a scar pregnancy, but they may achieve a live birth. The case series present evidence upon which to counsel patients with a scar pregnancy, enabling them to make an informed choice between the first trimester termination and continuation of the pregnancy, risk premature delivery, and risk hysterectomy, and risk losing their fertility. Now, I think that there is a prime importance of measuring the bladder to the sac distance. The literature is not only confusing as to the sac location, but rarely is there any information about bladder to sac distance or overlying myometrial thickness. Furthermore, usually there is no distinction between gestational sac and placenta. I showed you how the sac morphs into the uterine cavity. Lastly, there is rarely any mention about the location of placental vascularization. To correctly measure the sac to bladder distance, we need a precise definition of implantation, since it may determine the outcome. Sporadically, but increasing the literature makes a distinction between implantation on the scar tissue and in the niche, or for that matter, at the dehiscence. There is no consensus yet on the sac location. Comstock says low-lying versus surrounded by myometrium. Twickler talks about less than 1 millimeter that predicted morbidly adherent placenta. Nagy says away from the scar, close to the scar, crossing the scar, inside the scar. And Martha Rack says smallest anterior myometrial thickness on first trimester sonography significantly improved detection of morbidly adherent placenta. The importance is seen in these articles, but none of them defines it precisely. It is clear that there is no uniform agreed upon definition of the type and depth of implantation and its correlation to outcome. According to our 2016 study of 17 scar pregnancy cases who continued their pregnancy, 6 patients with scar pregnancies implanted on the scar and had a substantial better outcome. They had only 1 hysterectomy compared to 11 patients with cesarean scar pregnancy implanted in the niche millimeters in the first trimester ultrasound was associated with morbidly adherent placenta at delivery. Let's talk now about the treatment choices, if continuing the pregnancy is not an option. Well, here are the major treatment modalities. There are major laparotomy, minor laparoscopy, minimally invasive local injections with methotrexate or KCl, systemic treatments, uterine artery embolization or minor methotrexate injection, different combinations of the above, administered simultaneously or sequentially. The complication rate, however, is extremely high. When we reviewed 751 cases using 33 treatments, we found 44% of complications. The question is which treatment to use. The sporadic, mostly individual cases or case series and their results were insufficient to enable a clear conclusion as to which was the most effective, least invasive management protocol, leading to the minimal or no complications. Are there guidelines? Well, in 2016 and 2017 too, none of the countries, USA included, have a set of guidelines at hand when a patient with an early first trimester placenta accreta or cesarean car pregnancy presents. Analysis of the most frequently used treatment based upon our review of 751 cases and case series in the literature that were published until 2012, I selected several of them. First of all is systemic methotrexate alone. There are almost 560 cases reviewed in the literature. As a single treatment, they had a 64.6% complication rate and a 7.8% success rate only. Its slow action may take days. They have a questionable ability to stop the heart and often require additional treatment. Then there is the sequential or multi-dose systemic methotrexate. Be aware of its side effects. Even such treatment fails at times. However, methotrexate can be used as a very potent and effective adjuvant therapy, giving it with other treatments. Suction aspiration, a very frequently used therapeutic method. Sharp curetting, DNC, alone or combined with inflation of a Foley balloon to stop bleeding. About 305 cases were reviewed in the literature with about only 62% complications, mostly bleeding complications. If you plan for a DNC, have blood and a Foley balloon handy. Here you see the 3D ultrasound display of the rich vascular supply surrounding the chorionic sac of a scar pregnancy. This will explain the possible bleeding complications of the DNC when the scar pregnancy is subjected to curettage. Uterine artery embolization, it can be used alone or in combination with other treatments. And here you have a picture of before and after the use of the embolization. As a single treatment, it has almost a 50% complication or failure rate. It is not the best single or first-line treatment, but however, it's an adequate adjuvant to other treatments. It is a uterus-saving solution. Laparotomy and laparoscopy can be done, usually done in cases where the patient prefers this. There are very few cases reviewed in the literature. The complication rate is about 1/3. And it is due to infection, bleeding, and anesthetic complications. Operative hysteroscopy alone is a very useful and widely used treatment modality. There are about 120 cases reviewed in the literature. They have a fairly low complication rate. If there is complication, it's again bleeding because of the disturbance of the blood supply around the scar pregnancy. Transabdominal transvaginal ultrasound-guided local intragestational sac injection of methotrexate or KCl, which can be done, as you see here, transabdominally or using the transvaginal probe. About 100 cases in the literature were reviewed with about 10% complications. Here are the two articles that summarize the experience of the cases done in the United States, which count about 100 at this time. Transabdominal transvaginal guided Foley balloon placement to prevent bleeding after local injection of scar or cervical pregnancy. It can be done by transvaginal, transabdominal guidance, and you can use it as an adjuvant to local injection, aspiration, hysteroscopic excision, uteroanatomy embolization, as well as laparoscopic excision. We wrote an article and published on this, and here is a picture that shows the effect of the balloon on the scar pregnancy. The use of the single balloon is demonstrated on this slide, when you can see that or alone without injection, but the lower shows you the injection of this case. When the catheter is placed in proximity to the scar pregnancy, it is inflated, and the pressure of the balloon does the treatment or stop the bleeding or terminates the pregnancy. We lately use a double cervical ripening balloon catheter as a single invasive treatment. The reason for its use that it is very simple. It minimizes patient discomfort, and several OB practitioners are familiar with its use in the labor and delivery to treat, to induce labor. You can see its effect here, where the double balloon is inserted into the uterine cavity. The upper balloon is inflated. It serves as the anchor balloon, and the lower balloon then is inflated opposite the cervical pregnancy or a scar pregnancy, and performs the treatment. Here you can see the final result of it, showing the anchor balloon inflated, the lower balloon inflated, and the pressure put on the gestational sac. We suggest the management of the scar pregnancies according to this guidelines. If we do not have a heartbeat, we recheck it after several days or follow it until it's zero. If there is a heartbeat, we give the patient evidence-based counseling. If she wants a termination of the pregnancy, we do it without delay and monitor the HCG weekly. If the patient is interested in continuing the pregnancy, we determine the myometrial thickness above the area of the gestational sac. If the measurement is less than 5 millimeters, we advise the patient there is a high risk for morbidly adherent placenta and cesarean hysterectomy. If we see that the thickness is 5 millimeters or more, she then will be categorized as low risk for morbidly adherent placenta and low risk for cesarean hysterectomy. We have this multi-center experience now with more than 40 cases of the use of the double balloon. The patient tolerates the placement well. We give pain medication, paracervical block sometimes used to enable a painless pass of the catheter. We have very small amount of dark blood is exiting the uterine cavity after its removal, and the resolution of the HCG and the vascularity is seen within 50 to 80 days. We used it also to stop heavy bleeding into additional cases of scar pregnancies and cervical pregnancy. So to summarize the scar pregnancy part of this lecture, the diagnosis is difficult. It is usually misdiagnosed as low intrauterine pregnancy and cervical pregnancy or miscarriage in progress. The best diagnostic tool is high-frequency transvaginal ultrasound. MRI does not add to the diagnosis. The earlier the diagnosis was established, the better the outcome seemed to be. If possible, sharp curetting should be avoided. It causes profuse bleeding. If still the choice, have a Foley catheter available and of course blood. Systemic methotrexate as a one-shot single agent should be avoided. Good adjuvant to other treatments. Embolization as a single agent should be used sparingly, if not at all. Again, it's a good adjuvant treatment or a good solution to spare the uterus. And lastly, early recognition of scar pregnancy and of early placenta accreta starts with patient education. At the time of discharging women from the hospital after a cesarean delivery, patients should be advised that in the future pregnancy, an early visit 1 to 2 weeks after a missed period at the obstetrician for a transvaginal scan is of paramount importance. Recurrent scar pregnancy is about 1%. Since the scar pregnancy is one of the precursors of morbidly adherent placentae, the next section is devoted to that subject. The terms in the literature are PAD, MAP, and AIP, abnormally invasive placenta, and all of these really encompass accreta, increta, and percreta. It is a major healthcare problem. It accounts for about 33 to 50% of emergency peripartum hysterectomies. Its consequences are hysterectomy, blood loss, ICU admission, injury to adjacent organ. The risk factors are placenta previa, previous cesarean delivery, age, and others. However, the most important are really the first two seen here. My goal is to review the two major diagnostic modalities, ultrasound and MRI, used at the present time to attempt the most precise prenatal diagnosis. And my reason is that there were significant changes in the past several years in the evidence for various techniques used to make the diagnosis. Also, new clinical histologic data emerged about placental adherence disorders. There are three clinical forms of placental adherence disorders. First is the scar pregnancy we talked about. The second one is the second trimester early accreta, which I barely touched. And the third one is the full-blown placenta accreta, increta, and percreta. Each has its own sonographic appearance, clinical signs, natural history, clinical consequence. Each could be considered a different clinical entity. However, there is proof that there are expressions of the same histopathologic entity. The main statistics are shown here in this graph, and it says that the morbidly placenta rate increased in all the world up to 2004, but the trend continued even later. For every one placenta percreta, we see about 3 incretas and 16 accretas. Now, yes, this was true in 1977. I don't think it's too much different right now. The reported incidence has increased from approximately 0.8 per thousand deliveries in the 1980s to 3 per thousand deliveries in the past decade. This number is not really known at the present time as far as their distribution as of accreta, increta, and percreta. It is known that the risk of accreta increases with prior increasing cesarean deliveries. It increases also with the presence of placenta previa, but even without previa, the prior cesarean sections increase the risk of accreta. There are several theories. The most prevalent is the absent deciduobasalis and the Nitabuc fibrinoid layer in the scarred areas. And this slide demonstrates it, and you can see that the trophoblastic cells, that there are several kinds, invade the vessel wall. And if there would not be any kind of barrier, it would really go deep into the myometrium and consist and cause the known placental adherence disorders. However, this invasion is stopped by the metabook fibrinoid layer, as you can see depicted in this slide. Let's talk about the ultrasound in the second and third trimester. What are the ultrasound signs? First of all, the grayscale markers, clear space, bladder line interruptions, lacunae, and the thickness of the myometrium. And then there are two color Doppler markers, irregular tortuous vessels crossing the width of the placenta, hypervascularity of the uterine serosa bladder wall interface. And of course, there is the combination of the above. Here are the grayscale signs. The grayscale signs is, first of all, the hypoechogenic space between the placenta and myometrium depicted on the left side picture. However, on this one, you see two cases of placenta accreta, two pictures of placenta accreta, one with grayscale. The clear space is not non-existent and replaced by the vascularity in this area. The other one is the clear space. I consider this exactly the same as the previous one. It's a thinning, disruption of the hypoechoic interface between the uterus and the bladder. Loss of the normal bladder line. This is a normal bladder line above partially above the placenta. Here, the placenta causes an altered bladder line that is clearly seen with at least a little bit of urine in the bladder. This bladder line interruption can be seen with grayscale, with the upper pictures, the coronal and the sagittal picture, and the lower two pictures with color Doppler. So both will be diagnostic when applied. Lacunae. Lacunae are one of the most important signs of placental adherence disorder. These are irregular shaped placental lakes. They have turbulent, pulsatile, low resistance, high velocity, jet-like blood flow, extending from the placenta into the surrounding uterine or cervical tissues. They are located deep in the placenta, not under the fetal surface of the placenta. Here are the lacunae shown by the little yellow arrows, and they are scattered throughout the placenta, rendering it a Swiss cheese appearance. Here are a comparison between a normal placenta in the upper part and a lacunar placenta in the lower picture. These lacunae are really predictive of placental adherence disorder, and the more you see them being present, the more likely it is that it is a placenta parcreta. Finberg said that at least 3 would be important to mark an adherent placenta. Young graded them from 0 to 4, and Kali said that 6 or more being present in a placenta is equivalent with parcreta in 100% of the cases. The myometrial thickness between the placenta and uterine serosa has the same value as the clear space. The measurement of less than 1 millimeter, it is indicative of a morbidly adherent placenta, and it is probably the least specific and least sensitive sign. Color Doppler, however, is extremely important, and the color Doppler signs are the following. First of all, the irregular intraplacental tortuous vessels crossing the placental width. And you can see that shown here. They have increased vascularity extending from side to side in the width as well into the depths of the placenta. The next slide shows that clearly. Don't always look in the midline, because what is happening that the 3D ultrasound angiography shows the vessel along the incision line, and that is where you see their appearance most accentuated. The hypervascularity of the uterine selosa wall interface is also shown beautifully by this 3D angiographic rendering of the entire placenta. And this is a placenta previa creta at 20 weeks with 2 previous cesarean sections given me by Dr. Cali from Italy. Here is our own picture that shows really clearly the accentuated presence of the vasculature between the placenta and the bladder wall. So here is the summary of the sonographic basis diagnosing map based on an article by Dr. Kali, and you can see here the clear space, bladder line, lacunae, tortuous vessels, and the vessels under the bladder. If the 5 of these criteria were present in his series of 187 cases, in 141 they were no morbidly adherent placenta. If it was present, all 8 had placenta percreta. If 4 of them were present, then 8 had accreta and 8 had percreta. However, if none of these were present, all the patients practically had no morbidly adherent placenta. So for best diagnostic result, evaluate the patient risk, optimize imaging by using transvaginal ultrasound with a comfortably full bladder, use color Doppler with low pulse repetition frequencies, and report the findings as high risk, low risk, or intermediate risk for bleeding. If you are unsure, be conservative. False positive results are acceptable. The next question and the last area is whether MRI helps. And there are 3 major questions. Which are the best MRI signs? And are the sensitivity and specificity of MRI and ultrasound comparable, since ultrasound is really done first? Does this present a bias? And the last one, at what gestational age can MRI, which is a more expensive test, contribute additional information? So let's review this. Which are the best signs? The first one is the dark intraplacental bands on T2, and these are the most predictive, but also equivalent to the lacunae by ultrasound. And they are defined as being 6 millimeter or greater, and again, as I said, presumably correspond to the large vessels. And then there is focally interrupted myometrial border, infiltration of pelvic organs, and tenting of the bladder. The last sign, which was added not a long time ago, is placental protrusion into the internal os. Let's see them one by one. Here is the cross-sectional and the sagittal view of a placenta accreta, in which the yellow arrows depict the intraplacental dark bands. These are also some dark bands showed in one of the cases that was a proven placenta accreta. Focally interrupted myometrial border is shown by the 2 white arrows and the oval circle, clearly showing the penetration of the placenta into the myometrial layers in this case. The Novell sign, the placenta protrusion sign, is shown here. On the right side, you have a positive protrusion of the placenta into the area of the cervix. On the left side, you see the intact and negative placental protrusion sign. This article is useful since it would shed light on the MRI features of placental adhesion disorders and their diagnostic significance. It is a systematic review, and it's aim was to identify the most frequently used MRI features in the diagnosis of a placental adhesion disorder in the antenatal period and their significance. They looked at 614 relevant articles and only 11 met their inclusion criteria. The commonest MRI criteria used were the dark interplacental bands, heterogeneity of the placenta, abnormal uterine bulging, and disruption of the uteroplacental zone. A newly described criterion is disorganized vasculature of the placenta. The sensitivity of MRI varied between 75 and 100% and 65 and 100% respectively. Their conclusion was that MRI diagnosis of placental adherence disorders relies on unstandardized criteria of diagnosis. However, it is still a high diagnostic accuracy they have and frequently aids in surgical planning supporting the ultrasound. Most studies have small sample sizes, and they say that there is a need for an additional multi-center study that are recommended to enhance the findings and apply it to this pathology. Why it is hard to evaluate MRI articles? The study designs are different, with mostly multiple different interpreters. The low number of women in studies, that means that the power is low, and the variation of ultrasound criteria used for comparison. MRI is a reasonable diagnostic imaging modality. It is much more costly than ultrasound. It requires a dedicated expertise. It's not a primary imaging test. Its real effectiveness is hard to evaluate. However, it is close to that of ultrasound, and it should be used if ultrasound is inconclusive. Its disadvantage, there is no blood vessel information. So the answer to the 3 MRI questions: which are the best signs? Probably the dark bands. Sensitivity and specificity of MRI, is it comparable with that of ultrasound? Yes, they are, if ultrasound is done first. And at what gestational age can MRI contribute additional information? It is inconclusive before 24 weeks. The later, the higher the accuracy. And there is still no vessel information. So here are the final conclusions of cesarean scar pregnancies. The diagnosis of scar pregnancy is difficult. Scar pregnancy is often misdiagnosed as low intrauterine pregnancy, cervical pregnancy, or miscarriage in progress. The best diagnostic tool is high-frequency transvaginal ultrasound. MRI does not add to the diagnosis. There are no consensus on its management. If termination of pregnancy is the choice, proceed as soon as possible, since every moment, every day that you are applying the treatment later and enlarges the pregnancy and its vascularity. Scar pregnancy and MAP share a common histology, and it is a precursor of morbidly adherent placenta. Due to the increase of cesarean deliveries, morbidly adherent placenta became almost a daily diagnostic problem of the OBGYN and the imaging laboratories. Prenatal diagnosis became more reliable due to experience and the knowledge gained. Grayscale, but mostly color Doppler ultrasound are the primary dependable imaging modalities. If ultrasound is inconclusive, MRI helps. Continuing a scar pregnancy is a possibility. It can result in a live neonate, however, with the risk of cesarean hysterectomy. A multidisciplinary treatment approach is imperative. Thank you for listening.